All right. Happy Thursday, everybody. As Alec likes to say, that I like to say, it's an all internal affair today. Very, very excited for yet another Aaron case. I think those of you who watch this on YouTube have probably picked up the sense that we're suffering from a little bit of Aaron withdrawal. We're very, very happy to see him today. He's very busy. And those of you who are also suffering from Eugene Teaching Points withdrawal, fear not. Eugene is teaching today and again tomorrow. Let me hand the mic to them for them to say hello, and then we'll bask in the joy of two other people who are very closely related. Mike to Aaron and Eugene.
Everyone, it's Aaron. Just presenting another case this week, and I hope Vinny likes it.
Hi, everybody. I'm Eugene from Ghana, and I'm very happy to be back in the space of teaching points today.
Very happy to see you both.
See you both.
Today we have the return of a legend, Vinny, who is discussing Aaron's case today. For those of you who don't know Vinny, all you have to do is rewind the clock about 2.5 years to see him present case after case after case. And I think you're seeing Vinny, uh, more recent Academy member, step in your footsteps. And Aaron reminds me a lot of you. He made such a profound impact by joining and presenting and presenting and presenting. And I vividly remember you're doing the same. In fact, if you control F and type Vinny into the CP Solver's spreadsheet, you will see double-digit entries for case presentations, which is very, very rare. And for those of you who may not know, Vinny's impact in the space has been long-standing and long-lived, and he's actually one of the leaders of the very process that brings cases here, the case review committee. And so there's a small chance that you might bump into Vinny directly if you submit your case, and I highly, highly recommend that. So thank you for all that you've done in CP Solvers, Vinny. It's amazing to think that you're not even an intern yet, and so hopefully there's a lot more to come in the future. Uh, I want to hand the mic to you to say hello, but I also wanted to acknowledge a very touching thing I see, which is that Vinny's wife, Julia, is set up to do the scribing today, which I find to be a very touching and family gesture. So maybe you can pass the mic to her.
Yeah, so what a wonderful introduction. I don't recognize myself in this introduction. I'm just kidding. But yeah, it's super great to see Aaron presenting all those cases, and I was like reminding when I had the cases to present and everything. But well, I'm super excited for today's session, and it's kind of intimidating to discuss a case alongside Ravi, but it's also the one of the best experiences one can have in medical school and intern. But yeah, well, I'm super excited to um, Julia scribing, and it's great to have her just by my side here. And
Yes.
yeah, so Mike's yours, Julia.
Hello, everyone. Excited to be here, especially seeing Vinny discuss this case again. It's a pleasure to be here in this community, seeing you and Robbie and everyone here. Very excited for this session.
Vinny, I hope I didn't add pressure. Now you're probably looking on the whiteboard to see when is Julia discussing and make sure you scribe for her. Uh-oh. Anyway, Aaron, whenever you're ready, please take it away.
All right. So for the first aliquot, this is an 80-year-old male presenting for myalgias for 1 week.
Very
Okay.
interesting. Go for it, Vinny. What are you thinking?
Yeah, so my it's a pretty general complaint, and I would say it's not a common thing that the patient would like get to you and say, "Hey, doc, I'm with myalgias," but we can say that what is the understanding of myalgia here, and we'll try to start with the basics, just localize myalgia. Uh, Understand what are the possibilities related to example. We can. I don't want to start throwing like a bunch of diagnoses, but it's inevitable to think about rhabdomyolysis that is more tend to acute to subacute, and but we will start to think about also vasculitis, and we will just divide them in small, medium, and large vessel vasculitis that can curse with myalgias. We'll consider like infections also, but yeah, I would like start very broad and see what the patient has indeed in reality to tell for us in this such a broad space.
Yeah, I'm right there with you, Vinny. I think this is a powerful reflection that you just did for everybody to pay very, very close attention to because you're going to see hundreds of thousands, if not millions, maybe in the middle of flu season, over 1 billion patients who have myalgias. And so when the volume of such a chief concern is so high, it's really important to anchor yourself in how you're going to think about it systematically. And in your reflection, you both included very benign things like infections and very serious things like vasculitis. So I think a very simple question is to ask yourself, what do you know when somebody has myalgias and what is speculation? And what do we know? We know something very powerful, actually. And I would emphasize this is that we know often that the patient is hurting everywhere. And I want you all to pay very, very close attention to that, which is that the patient aches everywhere. And the truth is, it's actually not everywhere. It's usually often in their extremities. So when we're really saying, oh my gosh, my patient has myalgias, usually they say their thigh aches, their legs ache, and their arms ache. It's very rare that their chest aches, very rare that their abdomen aches. And so you ask yourself, wow, okay, I'm just going to ask myself, why is my patient's arms and legs hurting? And the beauty of that is it's not one arm or one leg, right? One arm or one leg often evokes local disease. When it's four extremities, two arms and two legs, the probability of a local disease is exceptionally low, right? So if you're following me, Vinny, you're like, huh, all we know is the patient's in pain, but we know two interesting things, that it is not the chest or abdomen, and it is every single limb. And by far and away, the most common thing to do that is a systemic viral infection for mechanisms we don't understand. Let's be frank, we don't know why flu makes people achy. So the only benign diagnosis that exists in the realm of myalgias is a transient, often serious viral infection. And so if you triage your patient to having transient myalgias, you are very likely to have a benign diagnosis. But if you don't have that as a transient benign process, whatever you're dealing with is serious because it is taking out and knocking offline every single extremity. So the hard job of taking care of 1 billion people with this kind of concern is to realize that 90% of them have something benign. They have a transient viral infection, characteristically a more serious one like flu or COVID. So the question for us, Vinny, is how do we decide which patient with myalgias to pay more attention to? So now that you're preparing for intern year, I'd be really curious, in what patient would you sort of stand up and say, this is unusual for a benign viral cause? What do you think?
Yeah, so I would say like if patient is starting to get like hemodynamic unstable, that's for sure. So I just remember the patients with dengue that they can start or chikungunya, they can present
Good.
with kind of initial benign curse that it
Very
doesn't look
good.
like to be very serious. And then like by the end of 1 week or some like some days, the patient starts to deteriorate and had
Good.
along like accompanying symptoms that would be arthralgias and lab
Very,
remarkable findings in both lab or imaging.
very
So
good.
I would look for those kind of things like associated
Very
both
good.
symptoms and disturbances in imaging and labs.
Very good. Let me try now to help you take that very large checklist and simplify it to three things. And those three categories you already gave examples of, but it's actually just three categories. The first and most obvious thing, Vinny, is when the myalgias last for a long time. You will never diagnose myalgias from influenza lasting for 1 month, right? So duration. And then depth. Now, Vinny, this is a little confusing. Let me explain to you what I mean by depth. If the disease starts to extend into the chest or abdomen, it's deep. So, what are examples that you said? Hemodynamic compromise. Hemodynamic compromise is here, right? Heart, lungs. Severe nausea, vomiting, here. So, if it extends into the abdomen, or it extends into specific structures in the extremity. And what are examples you said? The joints are swollen. The muscle is weak. The pulses are not palpable. 90% of myalgias, of people with myalgias, will not break any of these rules because they will have a self-limited superficial process. Two S's, self-limited, superficial. What are the red flags for myalgias? The two D's, duration and depth into the thorax and belly or into the extremity itself. So as we move forward, we have to pay attention. Does this patient have these two D's? 1 week? Not yet, right? 1 week. If he said 1 month, then for sure. So now we have to pay attention to, does he have depth into his chest and belly? Or does he have depth to involve a specific structure in his extremity? Is his muscle dysfunctional? Is his joint dysfunctional? Are his bones dysfunctional? Or are his vessels dysfunctional? And so let's see if we can build a case for a benign cause, and maybe Aaron is making me happy by presenting a bread and butter case. Or maybe Aaron is making everybody else happy by presenting a very difficult one. We'll see. All right, Mike, to you, Aaron. What do you have next?
All right, so some more history. For the last week, he noted onset of like generalized myalgia, which was worse in his bilateral lower legs, and this was associated with difficulty ambulating. And what he said was loss of balance secondary to the pain. This was associated with anorexia and generalized weakness. For the review of systems, he didn't have any fevers, chills, cough, colds, any dyspnea, chest pain, shortness of breath, or trauma.
Aaron, you're a master. It's almost like you knew what we were going to say. So, Vinny, you had a checklist. What do you think? Are you worried or not worried?
Yeah, so I'm kind of starting to understand a little bit better the situation here, and I would say that like the balance here, it's not like in for a center. The loss of balance here is not secondary to a center cause. It's more related to would be more related to the myalgia and the pain per se. But like we need to consider that, and the anorexia here is well the generalized weakness. So the anorexia here, it could be secondary to a malignant process and loss of weight secondary like perineoplastic syndromes, or but I would say that this is a acute issue and or would be lowering the threshold, but well, we need to think about it now also. And yeah, let's see. So the night fevers, how the infection possibility, we are thinking about that also, but it doesn't look like we need to. I don't want to precipitate myself and like start to exclude a lot of stuff. But well, it also will depend on the epidemiology and where is the patient being receiving medical care, and well, the shortness of breath, loss, the denial of shortness of breath and trauma or even abdominal pain makes us not so preoccupied with as you said, the depth of the myalgia here. But yeah, I would like help you to organize my thoughts. It's just
No,
throwing up things here.
I, I disagree. I think your thoughts are superb. In fact, I honestly have nothing to add. This case is a little bit, you could say the fact that he can't walk, that means the process in his extremities is deep.
Mhm.
But you could also say maybe he's not walking because how painful he is, in which case that's not deep. You could say the anorexia means the process is deep because now it's affecting his abdomen and he's not eating. But many people with viral syndromes also have anorexia. So I think the question that we have to try to figure out is, are these things clues that this process is in fact very deep, or are they markers of just a severe manifestation of something that is benign? And I think this is where ultimately the following principle is a universal truth in medicine. The eyes are much better than the ears. Let me explain. When you're hearing a history, you are getting often information from an untrained observer, the patient. The advantage that that untrained observer has is they know their body better than you can ever imagine. That's why information from them is incredibly valuable, and without which you don't know what to do. You have no idea. But your eyes, especially with more experience, are what you are training. You are training to say that person who has abdominal pain, they look very sick. That person doesn't look sick. So now our ears are telling us, hmm. And maybe if this patient were a healthcare professional, their quality of their history would be higher, potentially, because of the training they've received. And so I think right now we need our eyes to say, "Ooh, what's happening?" And so if we hypothetically, Vinny, if we walk him and he falls, that's deep. If we see that because of his anorexia, he is dehydrated, uh, tachycardic, hypotensive, that's deep. But when we look and we see somebody who's smiling and saying, "Oh, it just hurts," and he walks, but it's like, "Oh, it hurts," very different, right? So uh, remember that in your training, what you are doing is training your eyes to be a better, better, and better observer. And let's see what our eyes eventually show us. I think Aaron may or may not have more information, but I think for me, I'm not yet ready to commit if this is deep or not. But even because it's possibly deep, I now realize how crucial the physical exam will be to help us make progress. Did you have something to add, Vinny?
Yeah, no, I was just
Yeah.
about to say that yeah, I would be curious for to do like a careful physical examination,
Hmm.
a scan examination for the
Yeah.
possibility of uh necrotizing things that will be kind of related to myalgia,
Yes,
and then expand the diagnosis. But yeah, I would be curious to know what Aaron had to us.
indeed. What you got next, good sir?
All right. So, for his past medical history, this patient has HFpEF, hypertension, rheumatic heart disease with aortic stenosis, status post AVR, also with mitral stenosis. He's had a CVA. He has MASH, Barrett's esophagus, gout, chronic ITP, and he's status post cholecystectomy. So, for his medication list, he's on metoprolol, aspirin, atorvastatin, allopurinol, colchicine, furosemide, omeprazole, resmetirom, which is for his MASH, and avatrombopag for his chronic ITP.
Aaron, um, I will share with you my deep gratitude for how you're presenting this case. It is just so skilled. Um, yeah, I think there's a lot to work with here, Vinny. I'm curious, what jumped out to you? What do you think about this medical history?
Yeah, so it's inevitable to like the patient is to think about the statin-induced myopathy,
Mhm.
and the patient is receiving atorvastatin, and I don't know for how long, and I don't have like clinical experience to see if those if this etiology can present after a long time using the statin, or if they had a different dosage of the uh, of the medication right now. But on top of that, there's MASH also here, and this lipidemias, depending on patient, could be very hard to control, and these can be a contributing factor for to start about the hepatic metabolism to be impaired and being a factor that could contribute to the myalgias. But I would say that here the myalgia is just the one of the points, and this patient is a very complex patient, complex patient with a um, advanced age, profound history and comorbidities. And maybe the patient is anchoring on something that would be not the real thing, or it may be. So I would be very open to like further diagnosis, and I would consider, like, as I said, possibilities of malignancy, and what else? I don't know what is the as you said that the avatrombopag is for the yeah.
Nice.
It's for the chronic ITP. I cannot like expand on that. And the patient can be when I hear this multiple valve diseases, I am really considering the fact of any cardiovascular issue here. But I would, at this first moment, I would say that it's more difficult to relate with the initial clinical picture, because, like, with more than one valve disease, and this patient still have any all preserved walls and function, and also despite having on top the hypertension, but also had like complications such as the CVA. I would like to know about the in the chart had any investigation about the possible CVA. And I would say that it's a lot of stuff to work on. What what do you have, Ravi?
I have a fun exercise for you. Okay? We're gonna
Mhm.
practice what's called reflex ordering. Okay, so you're an intern next year, and you have to now, before examining the patient, put some orders in the computer for labs. Okay?
Mm-hmm.
What are your first 30-second orders? What do you want to order for him? And I will put them for you. Just say them really fast, really quickly.
Sure. So
Go.
I would like to have a CMP, CVC,
Yeah.
and a HIV, CK,
Yeah. Yeah.
ESR, VHS. What else? And the influenza and
Good.
COVID.
Very good.
That will be
Oh
the
my gosh. You'll take excellent care of this patient. Excellent. All those I completely agree with.
Mhm.
Now, before seeing the patient, what treatments do you think you want to order for him to help him feel better?
uh so it doesn't look like I would wait for the physical exam to see if
Okay, good.
there's dry mucosa, and
Very good.
see if this patient need any fluids.
Very good.
No. Well,
Very good.
yeah,
Very good.
I would need to wait for the physical exam.
Yeah,
Yeah.
excellent. Excellent. Very good. I completely agree with you. Let's get that exam and see, because we always have to think whenever you're getting information, do you need to get things going? So I completely agree with you. I think why don't we get that exam and see what it's towards, but let's put those orders in and have them cooking. We wait. All right, Aaron, what you got?
All right, so for the exam, so the patient's afebrile, the heart rate is 70, the blood pressure is 109/43, the respirations are 19, and he's satting 100% on room air. So his exam was otherwise unremarkable. I'll only be mentioning the pertinent. So for his skin exam for his lower extremities, there's 1+ bilateral pretibial edema with tenderness to the bilateral tibias without deformity. And also for the lung exam, there were diminished breath sounds bilaterally. For his neuro exam, it was otherwise unremarkable. He was able to ambulate without difficulty, just complaining of pain.
All right, there you go. Thanks, Aaron. What do you think, Vinny?
Yeah, well, what about the volume status? Any dry mucosa? Well, but just before you answering that, the diminished breath sounds, is there any crackles or any thing accompanying to that, or the patient can well can what is the BMI, or maybe you cannot just hear clearly the breath sounds, but it's just in the base, or it's on what part of the lung. There is diminished percussion. Like I would like those things to access better volume status, but there's a kind of very different pressure between the systolic and the diastolic, and but the patient like it would get an also and well maybe I don't know if ECG, but to see if it's sinus, but well the edema does not concern me that much. How it looks like it's about bilateral and the same appearance. Uh, yeah. Well, what do you think, Robbie?
Yeah, I think, if the patient's chief concern was shortness of breath and orthopnea, you might think, oh my gosh, he has acute decompensated heart failure, but he doesn't have that as a concern. And in fact,
Yeah.
not only does he not have that a concern, he can walk just fine, which tells you that his ability to exert himself is just fine. So I think if we go back and answer that original question, Vinny, is this process deep or not? I think the answer to that is it's uncertain. It's hard to know. And I think you need all the laboratory tests you order to figure that out. And I think fundamentally, he doesn't have any dysfunction in his legs except the edema. So the question is that a clue to something that's going on? And so I think your initial laboratory orders are fantastic. The only addition that I think is crucial is if you remember what things we talked about that can be dysfunctional in the extremity. We said muscles and you got CK. We said joints and we got an exam that doesn't have arthritis. We said bones and he doesn't have any focal tenderness to palpation. And then we said vessels. And I think anytime that you think that you are thinking vessels and you know that there is a structural vulnerability in the cardiovascular system here, the bioprosthetic valve, you have to worry about endocarditis. And so the only additional blood test I would consider in this patient is blood cultures. I think they're can be very, very sneaky. Now, to answer your question about empiric treatment, I think if this person turns out to have rhabdomyolysis, as you already brought out, you would be remiss not to give them fluids. The truth is, in most centers in the United States, in 1 hour, you will have that CPK. So it's not a life or death decision. But you can take a lot of advantage of the fact that of bedside observations. And so, what I would be inclined to do is I would probably just wait for the CPK to come back to make the decision about whether this person has rhabdomyolysis or not. But I encourage you all not to just order urinalyses to see if the patient has clues for CPK in the urine, but to look at the urine yourself. And many patients who have rhabdomyolysis enough to need fluids often have a deep tinge of a not quite dark urine, but almost a tea-colored hint to their urine. And that's actually how we decide in many instances to get a CPK or not. And so, yeah, I think I'd be really curious what the labs show, especially the CPK, because of his syndrome. And I think I would probably wait to give him fluids. But if I saw when he urinated at the bedside to send to the lab really, really dark tinged urine, I probably would just go for it and give him a liter of fluids while waiting.
Yeah, that was a thing that kind of missing my sending urine, and well, I also missed that the patient's not in acute distress, so we don't need to be in a hurry to
Exactly.
yeah
Exactly.
to
Exactly.
do intervention. So yeah, that's
Yeah.
all I have so far.
Awesome. All right, Aaron, what you got next?
All right, so I have two aliquots left. These are just two chunks of data. So the first set of lab data I'm going to give you includes the CBC. So the WBC count was 6.4, the hemoglobin was 10.3, platelets are 141, and the MCV was 73. So over the chemistries, the sodium was 128, the potassium was 4.4, fluoride was 95, Bicarb was oh, just kidding. I don't have the bicarb. The creatinine was 1.1. The BUN is 26. The glucose is 98. The calcium is 9.2. The magnesium was 1.9. For the LFTs, the AST was 481. The ALT was 292. The ALP phos was 233. For the total bilirubin, it was 1.8 with direct being 1.2. The albumin was 2.8. We also got PT and INR. The PT was 11, INR was 1, and the PTT was 38.7. Serum osms were also gotten, which was 273. The UA showed large blood with 1 plus protein and 0 to 2 RBCs. And the chest x-ray was also done, which was unremarkable.
Aaron, this is amazing. Okay, Vinny, are you ready for a breakout room just to mix your thoughts and learn with your colleagues, and then we'll come right back in 5 minutes, okay?
Sure.
All right. See you all very soon. There we go. All righty, Vinny. So, what'd
Wow,
you
this breakout room saved me. It's so great to have like a few minutes to think about it.
Yeah, I know, right?
Yeah, awesome. Well, so let's take step by step, baby steps here. So the patient
Yeah.
is slightly anemic. I would be curious for the MCHC. We can see by the MCV that is microcytic, but the patient is 80 years old. So I wouldn't prioritize that at that moment because we have other labs that I have more that would drive more my attention. So there is a slightly hyponatremic, but without any kind of symptoms right now. So I will need to open the algorithm of hyponatremia because I don't know that from the top of my head. And what else? The creatinine here is normal. The UA, the patient has large blood without RBC, so that points more towards a myoglobinuria or myoglobin pattern for me. And well, we have here a cholestatic pattern of injury with a proportion of AST almost the double of ALT, and AST is present not just in the liver, it's present in heart, muscles, and we had like a lot of discussions in the academy regards that. And so what this makes me think makes me think more towards muscle,
Mm.
and well, we'll then consider the bilirubin with a more directed pattern, and I would leave you the serum osmolarity for you to make the hyponatremia algorithm. But well, going a little bit further, I would consider that we can expect that the CK will be through the roof or will be high, and that all of that would point more towards a muscle etiology here. So the patient is receiving atorvastatin, and the statin-induced myopathy can be caused just right after initiation of medication, but it can be caused by any time. And I would expand by exogenous toxins, so cocaine, we need to consider here. If the patient had in the previous weeks any runny nose or further symptoms that points towards a infection, or I would consider like viral etiology, so viral myositis. And if the patient is again from Brazil, I would, or well, anywhere in the world, India, well, anywhere in the world that the epidemiology would point toward dengue, chikungunya, and so on. And finally, we are not seeing so far profound electrolyte
Yes.
derangements, but these can be also an etiology of myositis here or myalgias. Yeah.
Excellent. Absolutely superb. Guys, if those of you who are listening to this, you're like, oh my gosh, I want to learn more from Vinny and hang out with Vinny. And I just wanted to show you, he is the leader of the case review committee. You should join. Here's how you do it. You just go to the website, clinicalproblemsolving.com. You hit on morning report, and you can sign up to join us live if you're not doing that already, or you can click here and say present a case. And then you write your name, and Vinny will receive your message and pair you up with a mentor. Oh my gosh, that's amazing. Sorry, Vinny, I just have to plug your work over and over and over again because I have nothing to add. I think that was superb. My only small reflection is the diagnosis of muscle disease, which you walked us through, was made a little bit harder by seeing that there is a high bilirubin. Because in a case of pure muscle disease mimicking liver disease, you would see that the bilirubin is normal. In fact, you would just see an AST to ALT that is very high. Ratio is more than 2:1. And so you would come to the conclusion that this is from the muscle. And so here, the patient's bilirubin is high. And this is why it's so hard to diagnose muscle diseases in patients with pre-existing liver disease. And this is why Julia so kindly highlighted his MASH, metabolic associated steatohepatitis. We know he has chronic liver disease. So we suspect that the bilirubin and the alk phos, which do not come from muscle, are likely from his chronic disease, and the acute AST and ALT elevation are from the muscle. And we have almost near complete proof of that because in the urine, we see by the fact that there is large blood, the blood dipstick doesn't test for blood, it tests for globin. Myoglobin, hemoglobin, and here, the fact that there is no red blood cells makes hemoglobin less likely. The possibilities here are hemolysis with free hemoglobin or myoglobin. And while hemolysis is possible, his presentation of myalgias is very evocative of the CPK. So now is the time for some IV fluids, my friend. And if you are a senior member of this community seeing many patients already, I encourage you to think about avoiding the diagnostic delay of 2 or 3 hours while the patient is sitting in your emergency room or acute care not getting fluids. You could just say, oh, no problem, it's only 2 or 3 hours. But if you are pushing yourself to be not just accurate in your diagnosis, but efficient, you can make this diagnosis well before the labs come back, because one glance at the urine in this patient and you say myalgias plus dark urine at the bedside, 2 hours before these results come back equals fluids. And that way you accelerate the care of your patients. And your call to the medicine team is, this is rhabdomyolysis admission, and I have already given the patient 2 liters of fluids, as opposed to this is rhabdomyolysis admission, good luck, right? And we strive for that, not just accuracy, but efficiency. And I think that's the point that I think we can emphasize. So, Vinny, just one small teaching point about the cause. So here you are seeing something unique. Your knowledge about statins is excellent. I would also use this case as an opportunity for you to learn about colchicine. Colchicine has the same similar toxic properties to muscles as atorvastatin. Unfortunately, these medications can also act synergistically together to increase the risk of rhabdomyolysis. Colchicine is especially notorious because not only does it cause myositis and rhabdomyolysis, it causes a unique form of neuromuscular toxicity called neuromyotoxicity. Because not only does it damage the muscle, it also can damage the nerves and also cause a severe peripheral neuropathy along with the myositis. So here, I think the dilemma will be not just to hold the statin, but to hold also the colchicine, and to know that these medications, when combined, increase the risk of rhabdomyolysis. But let's not talk too prematurely. Let's see what Aaron has as the final aliquot, and then we can reflect together. All right, Aaron, mic to you, my friend.
All right, wonderful discussion. So for the final aliquot, just the labs that everyone's waiting for, the CK was 5,939, and a trope T was also done, which was 179. They also did a CT of the abdomen and pelvis just to rule out any biliary pathology. The CT showed Q status post cholecystectomy, no biliary ductal dilation or radiopaque choledocholithiasis, the lobular contour of the liver with a prominent spleen and probable upper abdominal varices suggestive of cirrhotic change. And I'll leave it at that.
Awesome. All right, Vinny, what are you thinking?
Yeah, all right. Well, awesome. And just one differential diagnosis that I forgot to point when I was thinking about the differential diagnosis is trauma. It could be another cause of the rhabdomyolysis. And here, I would say that on an elderly patient, would you another possible etiology is heat stroke here, but the patient is afebrile and it doesn't look like the situation. But yeah, I would think that it's very nice that it did the abdominal imaging here to rule out like the cholestatic pattern that we mentioned. And I'm thinking that, as you said, like looks like the both the etiologies here, the risk factors that the patient had using the medications that you mentioned on top of the MASH pattern and the cirrhotic liver, it makes the ideal scenario for having a rhabdomyolysis. Oh, that's it. What do you think, Ravi?
Yeah, no, I completely agree. I think that's probably what we're going to have to do. Management principles, the troponin I here is not a true
Mm-mm.
positive because the patient doesn't have any features suggestive of. There's a high rate of cross-reactivity between the CPK and the troponin T assay. So I don't think that I would be worried about this patient having myocardial injury. Um, the height of the CPK is not very high. Technically, when the CPK is over 5,000, people recommend admission for hydration. In my practice pattern, I'm very, very cautious of admitting people to the hospital because it removes them from their lives and gives them yucky food and no socialization, no windows, and often no joy. So, in a patient like this, my management would likely be to aggressively hydrate him in the emergency room and recommend discharge. If he felt very uncomfortable with that, we would admit him in a heartbeat. But I encourage you to be a little bit more thoughtful about your admission thresholds because admitting a patient, if you yourself or a family member have admitted to the hospital, I'm sure you'll know this, it is very, very disruptive. So the question is it worth it? And for me, in his case, I'm not sure that's the case. So yeah, just two small points. The CPK, the troponin I is probably not real. The CPK is not super high, so I think we can probably support this patient in the emergency room and get him home. But let's learn from Aaron. What happened?
Yeah, so this patient was actually admitted, and yeah, they said the same things with the statin and the colchicine. However, the main culprit they were putting their money on was actually the resmetirom, which is Resdifra, which is actually can cause rhabdo in the setting of MASH. So I learned that it's for MASH. It's a liver thyroid hormone receptor, and it basically just boosts the like metabolism in the liver to break down all the fat. And yes, people, especially who are already on a statin and colchicine, who are started on Resdifra can get rhabdo. However, the interesting for this patient was that there were no changes in his medications for a while now. So he's been on these medications for a month. So the final diagnosis for this case was non-traumatic rhabdo secondary to the resmetirom, but also with the statin and colchicine contributing.
Aaron, this is an unbelievable journey with so much learning along the way. Thank you so much for presenting it. I'm curious, how did you change the management of this patient going forward? What medications did you discontinue for the future?
Yeah, so we s- um, the hospital stopped everything, just the resmetirom, the statin, and the colchicine, and I saw this guy on follow-up at our clinic, and the
Hmm.
most recent CK went back down to 100.
Yeah.
So I think we're planning to slowly um, put back his colchicine and statin, but I think we were monitoring the labs first, just to make
Yeah.
sure, if
Sounds
he
good.
actually needs these medicines still.
Right.
So yeah,
That sounds like
going from there.
a gentle, slow restart. Awesome. Yeah, Vinny, what are your reflections?
Yeah, so well, thank you, Aaron, for presenting this case. I would never have guessed the Resdrifa. It's not a thing that I'm familiarized with well, but thank God it's a case that at least we can like spend a great time because that was like a narrow case, I would be totally miss it. But well, it's a wonderful presentation, pristine, and a lot of amazing teaching points that you had for us. And well, thank you.
Vinny, it was such a treat to discuss with you. I think the delta between the past and the present is huge, which means that will likely continue that trend. And I think next time we discuss, you will not recognize this discussion and so on and so forth. So congratulations to you, Julia. Thank you so much for scribing and for the strategic highlighting of things along the way. It helped a lot. We have Eugene waiting in the ranks for teaching points, but before we go to Eugene, Yusuf, who is here, has a special surprise for you. I figured, Yusuf, we would make the announcement of what you have planned for folks before we hand the mic to Eugene, so it's not an abrupt statement.
Yeah,
Mic to
hi
you, Eugene.
everyone. Anyone who presents cases joins our academy, and in the academy we have a lot of learning, spontaneous sessions where we teach and learn from each other, and we call those rapid fire sessions. And Kirtan and I are going to have one right after the session, a quick where I present a case that I saw last week. So if you want to stay on the call, you're very welcome.
Awesome, Yusuf. Yeah, so I'll stop the recording after Eugene's delivery of the teaching points today. And for those of you who are joining us, you're more than welcome to stick around on the Zoom to get a sense of what the Academy sessions are like. It won't be publicly launched, but you are free to consume it here and hang out and learn with the team. Eugene, the mic is yours, my friend. Take it away.
Thank you so much, Dr. Rabi. Thank you, Vinny, and thank you, Aaron, for such a wonderful case discussion. And so we had an 80-year-old male who has a past medical history of chronic liver disease and MASH, and then also gout, and also has some other risk factors that require atorvastatin. Was on colchicine, and then also resmetirom, if I'm pronouncing it right. Presented a 1 week history of myalgias, and right on, we wanted to understand which areas of the body are involved. And Dr. Rabi mentioned that usually is the extremities when somebody is complaining of myalgias, that is the extremities that actually are hurting. And what would help you make any progress with it is that you want to consider whether it's a single extremity or multiple extremities. So multiple extremities can start putting your mind to think that this may be a serious issue, but a single one, you may think it's local and less serious. And then you also want to consider whether it's just superficial or it's involving deep structures. And typically, when it's involving deep structures, there may be other systems involved, like the chest or the abdomen. These structures that you're worried about includes the bones, joints, vessels. So does this patient have any pain in the bones or joints, there's arthritis, or some vessel issues? And so some etiologies that Vinny pointed out could be that if this patient is having a viral infection, so a multi-system viral infection can actually precipitate myalgias that are affecting all the extremities. Also, inflammatory causes like vasculitis can also do that. And Dr. Rabi mentioned that 90% may have self-limiting superficial disease, but then the red flags will be the depth and extended duration. So we started looking for clues that can help us locate depth. Duration was just 1 week, so we're not holding so much on that. So we considered anorexia and generalized weakness, which Vinny mentioned that could points to some underlying disease like a malignancy or inflammatory process, or maybe not. So we went on, Dr. Rabih mentioned that what can actually help you to make progress with such information is, so the generalized weakness, you want to have objective data. So observe the patient move, and if the patient is falling, then you can think that, okay, that is actually pointing to some underlying disease. We still went on to look for clues from the past medical history, which and then the medication history, which pointed to this particular case. That is a rhabdomyolysis from the resdifra or resmetirom, which is actually a medication that is used to treat MASH. And Aaron mentioned that it actually works on the thyroid hormone signaling in the liver, and that's in effect, when you are increasing the thyroid hormone signal, you're actually going to increase muscle demand. Muscles will be demanding more ATP, and if they're not getting enough energy, they are going to break down. So that's where you have rhabdomyolysis. Things in the labs that also give us some more clues, which I want to point out because they are very great teaching points, is that when you have elevated AST ratio to ALT ratio, you can think about muscle disease comparable to liver disease, but other things in the liver panel that pointed us to the ongoing chronic liver disease was the raised bilirubin and ALPs, because you can't have that in just purely muscle disease. And then the UA, which showed large blood. UA doesn't really pick red. UA measures globulin, so it could either be hemoglobin or myoglobin. In this case, if you're not having red blood cells, in addition in the microscopy, you should be thinking about myoglobins. And so coupled with the CK, we're able to make the diagnosis of rhabdomyolysis. And so a fantastic case, packed with a lot of rich learning, and I'm excited to be a part of it. Thank you.
I can't hear you, Rabih. I don't know if it's
Oh
just
my
me.
gosh. I'll say it again. Thank you, Yusuf. I said, Eugene, there's only been one professor in CP Solver so far, and that is Prof. Rez, but I think today we should officially announce you as the second professor. That was such a clear professor-like distillation. So calm, so relaxed. It was absolutely beautiful. Kudos to you, Prof. Eugene. I'll tell Reza that he now has a replacement. But worry not, Prof. Rez is never replaceable. I just wanted to say that I will miss you guys. Will be away from VMR starting today for like 10 days or so. So tomorrow you'll have a special treat. It'll be Dr. Ravi with Prof. Rez, and again Prof. Eugene in the around the teaching point. So a big thank you to you all for an awesome day, and I hope you have a great week ahead of you. Yusuf, I will end the recording and make you the host.